Nice to be with you this morning. Colm and Vida and Helen have articulated well, I suppose, what the purpose of digital is in healthcare, and I think it's important to remember that effectively Sláinte Care is our health strategy. That's what we're going to work to. And within that context, then research fits into that as well. And I'll come back to that a little bit later because I'm conscious that's the focus of this morning. But it's really important when we look at digital, it's an enabler. We had a discussion yesterday with the Swedes and the Swedish embassy about where they're at. They're one of the top countries. I hate to say we're down near the bottom, but when you're at the bottom, there's only one place you can go, and that's up. So there's a chance to maybe leapfrog as well. One of the things the Swedes were talking about is effectively they've taken away the word digital from all of their business and healthcare as well. It's the way of doing things. So I do think we have to look at that. This is about how do we do our work, how do we work in healthcare, and how do we work through that. So there's some of the examples in terms of the research papers around the action plan for research, the HRB, some of the department statement of priorities around research as well. So if I move it forward, our digital landscape, we want to reduce the reliance on acute hospitals, provide more care in the community. We want more control over healthcare. Clinicians want access to the right information. Public expectations have increased. You can go on to Paddy Power and lay your bet, not that I do that. You can go to your banking, you can do all of these things online. You can book your airline ticket. I worked in airlines 20 years ago in airlines. You had to go to a travel agent. It opened 9 to 5. So some service industries have transformed through the use of technology, and we have to look at that in healthcare. How do we do that as well? Technology advancements, AI is now the buzzword, but AI has actually been there for years. Machine-based learning, most people in healthcare actually have that in place all the time. And universal access to healthcare, mentioned earlier, Helen touched on it and others as well. Policies are there, demography pressures, learning from digital and pandemic. Colm talked about that. Huge learning. UCD, actually, where we are today, we set up a contact tracing centre with the help of the chief academic officers in 24 hours. So that's the type of thing that we have to look at going forward around it. EU policy and so on as well. So Digital for Care in Ireland, what is that? Better health outcomes enabled by seamless, safe, secure and connected health services. It's the government's policy in relation to healthcare. And there are 6 principles. Patient as an empowered partner is one, and that's, again, we've talked about that in the policy context. The health app is one thing that we're going to announce later this year, launch later this year, not announce. That's about giving patients access to that information. Digitally enabled and connected care is the second one, and that's the really important one because that's where the electronic health records come into play in terms of what's there. The ecosystem, the availability. Foundations is really important in terms of infrastructure, architecture, that we have all of that in place to enable that to happen. Data-driven services and workforce. There's 48 initiatives. I'm going to take you through them all one by one. You'll be glad to know I'm not. The initiatives really, you can get hung up on this stuff, and in some ways when this was signed off by government, the important thing with this is it's endorsed by government and our department. And it gives us a basis to go into deeper, the funders, to say, look, we need to do this in Ireland. The department working with ourselves have put a pitch in for the Apple money. We didn't want the Apple money as a country, but we've got it, so let's put it to good use. But either way, we have to invest in this to bring it forward. And as I say, when you're at the bottom, the opportunity is to try and build and go up. We want to be, those of you that might follow football, if you look at Disney with Wrexham, how they flew up through the divisions with a little bit of funding, a little bit of endorsement by the American actors and got themselves up into wherever they are now, League One or Championship football in England. So these initiatives are programs in one way, but some of the things are a little bit different. Medical device integration is something that applies across all our services. It's not a program on its own. And again, our Dr. Ger Flynn, who heads up our medical device programme, is integrated now into a lot of the programmes. So when we're rolling out EHRs, we need to consider medical device integration. When we're rolling out pathology systems, we have to consider integration. We did it with NIMS. Neil O'Hare is here at the front who would have driven that out. Probably one of our most successful national programmes, but still we've 3 hospitals to get over the line. So, we need to also look at how do we pace that out. So the 6 categories are really ways or principles of trying to group some of the things together to drive it forward. And the reason these things are important, and I'm not going to go through the whole 48, is it's all of the pieces working together is what makes the system work. The EHR undoubtedly is at the heart of it, but all of these other pieces also have to work to enable us to make this work as a system. So what would it look like by the end of 2030? Again, some of this, my thunder's been stolen by my colleagues in the department on DHDS, but you can see this is what it's going to look like. Patients, we should all have access to our own digital record. More importantly, I think, because again, healthcare is about contact with people, as Colm said, healthcare professionals will have more comprehensive information real time, and that's important. And thirdly, and this is really important, we are so parochial in healthcare. If we put it into Hospital X, I'll take the Mater because Tim's there, and it had to go across the river to Vincent's, the chances are en route someone would say, I need to change that. I can't do my cardiology that way, or mental health services are different. Yes, there are things that might be different between North Dublin and Donegal or Kerry, but are they really that different? Do we really need different solutions in all these areas? Do we need to add that complexity? Can we not agree best practice? I would always argue one of the greatest successes of the HSE has been the clinical programs that have brought standardization of practice based on best practice internationally and an evidence-based approach to how we do things. They can drive change through around it. So this is really key. Patients can move between settings, between regions. We change structures every 10 years, there's a cycle. The NHS is the same. So if you build something around a structure, and I do think the regional structures are the right structures, but structures can change. Ministers can come and go and change their minds. We had regions. I was involved in it myself and Brendan Drum's time, probably less than 10 years ago. Regions and IHAs, it was broken up again. So we need to make sure that when we implement these solutions, they're independent of structures, not just because structures change, because patients move. The person in North Dublin may go to Beaumont, the Mater, but could be in James's next week for a specialist appointment. Maybe on holidays in Kerry for 2 weeks and something happens to them or one of their families. So the systems have to be independent, patients have to be able to move, and we have to let go of our boundaries structurally, organisationally and professionally, and make sure that patients are at the forefront of that. So some of the programs that are there, and I'm going to keep an eye on the yellow and red cards down here with Anna. I've only ever had 2 red cards in my life. Both were completely unjustified. So I don't want to get one today that's justified. One in GA and one in soccer. And both, as I said, were just scandalous decisions. So I'll try and avoid getting that. Of course, I've long since forgotten about that. So some of the programs that are here, just to give you an illustration, DHR I'm going to come back to because that's a real cornerstone of your discussion today. But it's important to remember there are other really important programs that we're trying to implement and accelerate through Digital for Care and the work that our colleagues in the department have done. Bottom right corner is the resource piece, a system called SAP, the financial management system, the human resource systems. We've 24 billion, 160,000 people. We need to be able to manage that much more closely and understand the value and the cost. I was visiting a surgical hub on Monday in Newcastle, and it was a Derry girl that was the manager there, the nurse in charge. Fantastic. She was the real Derry girl. She ran a brilliant show. She knew the price of everything and the value of everything. There was a number of directors and nursing with us. You could really see she understood the value of running that facility. 4 theatres, 180 staff, a really productive day centre, and we're obviously committed to a programme here in Ireland. But it was really interesting to see that piece of value. So that system, that programme will help to do that, and that's well advanced and well on its way. If I move to the bottom left with the little wireless code, we need to get Wi-Fi in throughout our system. Sounds very simple. You ring Air, you get it in. When you get into the hospitals, we've discovered recently, our cabling is outdated. You're talking of hundreds and hundreds of millions of investment. You've got to time it when you can get into hospitals, infection prevention control, to enable the Wi-Fi to be implemented across the country. We've about 4,000 locations, but we need to get on with that. So we're trying to accelerate that programme. But again, big investment needed to do that, and we've expedited that project as well. Because without it, how can you ask a nurse, a doctor, a therapist to walk around a ward and have to walk 50 metres back to a nurse's station to look at information? You can't have it. We have to move that forward. The health app, which has been referred to earlier, will be the gateway for people to see their information, and that's going to go live in December, November, sort of date to be finally agreed over the next few weeks. Initially, that will focus on giving information to people on maternity women. Because we have an electronic health record in many of our maternity services, it's possible to do that. And the pilot that we ran in the south earlier in the year was really powerful. Women valued being able to get their information electronically, being able to link that to information about their care and treatments and so on as well. So there's intuitive pieces, and we'll gradually build that out over the next few years. In the middle then are the imaging systems I mentioned, or the diagnostic systems. I mentioned the medical imaging system, very successful. I've had my own experience, again, a personal story. My son years ago had a bad head injury in Sligo. The image was immediately readable in Beaumont National Centre and able to make a decision, transport or not. Immediate improvement in patient care versus picking up the phone, trying to have a dialogue up or down, and they have to manage, obviously, the National Centre really carefully. You make the wrong call, bring the wrong person, that can cause permanent damage. So there's real examples of where a system is valued in terms of care. It also obviously eliminated the old films. There's probably not too many people who remember those, but that was a huge cost saving as well. And we're now rolling out the Medalist programme live in Beaumont. Digital pathology will flow in behind that as well. Electronic ordering from GPs. So those systems are also going to be very important in this jigsaw. So I'm going to increase the pace a little now and just talk about the HR project. And it's great to have Dermot here from Northern Ireland. I do want to acknowledge our colleagues in the north who have done phenomenal work. I've had the privilege over the years of been chairing some of our cross-border work. 3 of their trusts are now live, 2 more to go. I won't go into the dates. Dermot will talk about it later, but it's been a real success. It's still very early days and a phenomenal project, and just to compliment them and their work. So again, that's something we'll be turning down south and saying we have to move in the same direction as our colleagues in Northern Ireland. So we have some implementations, but they're different projects: maternity, forensic hospital, rehabilitation hospital, children's hospital. Neil and the team, I think the children's hospital is due to open very soon, Neil, isn't it? So you'll have that system live. We're not giving the date out here today, so we'll leave that till after the election. Tala, again, another hospital, have done a lot of work. James's and other places. But they're all individual pieces, and we have to join it up. So what's our vision for the HR programme? We stood this up in June, and we have a steering groups in place, and we're starting to put a whole structure around that, and there'll be lots of opportunity for people to get involved. So don't worry, if you're out there in the system and you want to get involved, we'll be glad to take you on board. Implementing an EHR that gives one person, one record, one plan, and gives you up-to-date information. Now, this can sometimes seem a bit motherhood and apple pie, these statements, but that will drive the fact that we will look to put in a solution, number one. Number two, it has to be available to do things with it across regions or across hospitals. You can't just have one system in Galway and a separate one in Castlebar, and we're magically going to glue it all together and the word of interoperability will resolve it. So the core functions will be there. It needs to be independent of the continuum of care, work across it, geographical boundaries, and from birth to death. And there will be challenges along the way, but we're committed to making that happen. And the new regions, as Colm have said, will be the cornerstone of that. Our timeframes are there. I'm not going to spend too long on this. The first region is selected, so those of you in Dublin North East, like Melanie McCallion over there, will be the first. And the reason for that was a risk-based assessment in relation to systems and age and issues within some of the areas that are there. After that, our proposal is we look at a readiness assessment. Who wants it? How ready are you? How much are you prepared to step up to the pitch? And those that are prepared to get up there early will get first call. So that's the way we intend to try and work it through. The business case is going through it at the moment. It's a nice short document. Myself and Colm got it on our emails the other day. It's probably something about that size, and the supporting documents are something about that size. But that's what you need when you're going to spend about 2 billion euros. That's what we're probably talking about, 2 billion euros. So someone would say, God, that's mad money. The integrated ticketing system for Dublin went to tender recently for 1.7 billion, which in terms of value is going to give the greatest value to our nation. It is going to be in every village, in every primary care centre, in every hospital, used by 160,000 people every day for all of us. So we will certainly argue very strongly that is probably the best investment government can make in terms of healthcare to try and give us the opportunity to improve it. The procurement, the shortage we've seen is Alberta and Canada, about 16 or 17 months, and in parallel starting the preparatory work for implementation across all sites. And this isn't about the technology. There's systems out there today that work. We've seen them in countries, Australia. It is about the change. How do we want our health system to work? And it needs to be led clinically, driven operationally, and enabled by the technology. And that's really important. It's not the technology in itself. It doesn't matter which the vendor is to some extent as well. There's a number of vendors there, and we'll go through the process to select that. So we have a life cycle. I won't dwell on that, just we're at that stage at the moment in terms of our planning stage around it. There's benefits there. Others have articulated them far better than I can in terms of the examples Colm, Helen and Vita gave earlier, but you can see the sort of things that are there. Standards are going to be really important in terms of data. In the app on the maternity side, some of the women's appointments in the Northwest didn't come in. They're using the same system as everyone else. Why was that? The clinics are set up in a different way with different naming conventions. So standards are really important if you want information, even with the same system, to move across. And I have one eye on my cards down here. So the scope of services are there. They're in the slides. They're the traditional things that you'd expect to see with an electronic health record. And they cover all of our services. But as I say, some of the other solutions will be there as well. And I guess we have to move away from thinking in terms of, as well, mental health services, disability services, cardiac services. You're looking in some ways at functions, being able to order things, managing cases, managing medication. They're the sort of capabilities, support for clinician decision makers. And that's vital. There's a lot of hype about AI now and machine-based learning, but effectively it should be there to enable the clinician and support them in their work, rather than ultimately the idea that somehow there'll be this R2-D2 that's going to come up and tell you your diagnosis and bring it through. So there is, and industry technology is brilliant at hyping up things. All of that machine-based learning has been there for 30, 40 years. So in some ways, it's like, as they call it, the hype cycle is the phrase, but there is still lots of opportunity in terms of machine-based learning as we go forward. Data is one of the principles. I'm not going to talk too much today. I do want to flag it, though, because it is important in terms of analytics, and in a research capacity, it's really important, whether we're talking about developing registries, as Colm said, whether we're talking about pulling information together about people and making that available in a research context, whether it's within the HSE to have better planning on our winter, whether it's in academia in terms of research or whether it's on high-end product development with industry, who would love to get their hands on some of this data. And just getting to the end, there is a very clear commitment in Digital for Care that, and I've highlighted some of the key things, a research-friendly environment, use of healthcare data in a safe way and for secondary care purposes. And one of the reasons I was delighted Helen and the CAOs agreed to come on to our steering groups in the early stages is that that thinking is there, that challenge is there around how do we evolve this as we go. There's a really good slide from the EU that shows, again, how health data can be used. There's that core piece in the middle that supports on the left-hand side professionals and patients, on the right-hand side then, which is the space you're talking about today, around policy, about innovation, and for research, how do we make that available? So to avoid the red card, because I've just got the yellow card, there's three things I just want to leave you with, as they always say, the rule of three. One, it is going to involve some large change programs, ultimately including DHR. And those of you that work in the health system, that is about how do we make the system more efficient, more effective, and ultimately supporting safer care. The electronic health record program, whatever the price tag, will be a once-in-a-lifetime opportunity to try and look at how we engineer our health services. But it must be led as the clinical and service side. How do we actually organise our services better? The regions and the integrated approach, which is the way we're going. We all know we could never build enough beds to facilitate out the demand we'll face over the next 20 or 30 years. So we need different ways of doing things, and technology can support it, but shouldn't be the basis on itself. So there's a huge opportunity there for us, in my view, in that. And lastly, this will give a rich source of data to support research, to support innovation, both with industry and with academia. And I think it's important we build that in, and we will build that in as we go. And the last thing I'd say is, while EHR may take time to get in its totality, we can do a lot of this and build as we go. Research happens today. It makes the best use of the data it has. There's opportunities as we go through this if we try and plan that, design that into our data system. And we will be appointing in the HSE shortly a Chief Data and Analytics Officer to try and drive that data piece, standards, focus on data quality. Because when you're doing research, if the data is pretty rubbish, well, that pretty much affects your research on the other side as well. So the higher quality data we get, that's better for people running service, better for us as patients to be able to see accurate data, and ultimately as a benefit upstream as well in terms of research in industry and in education. So as I've just avoided the red card, I'm going to put my bits and pieces down. Thank you very much for your time this morning.